I'm going to introduce Dr. Jack Fu from Physical Medicine and Rehabilitation next to talk.
Thanks, Dr. Raza, for inviting me and having this great opportunity to speak to you all. I'm a physical medicine and rehab doctor here at MD Anderson. We're also known as physiatry. It's another name for our specialty, not psychiatry, but physiatry. So this is a tough talk. I mean, I got 15 minutes to talk about rehab in a nutshell for a diverse group of people who have probably diverse locations of their tumors and maybe diverse stages of their care. But I'm gonna try to tackle it as best I can. And really, the rehab issues that we encounter in our chordoma patients are really dependent upon where the chordoma is. So the neurologic impairments that a patient has with the skull-based tumor could be very different from one who has a sacral tumor. And really, what would be more important to look at is what is the stuff that lives around that area, and that would sort of give you an idea of what kind of rehabilitation issues we may encounter. So for skull-based tumors, up there in the skull base, the cerebellum kind of lives near there. There's a lot of cranial nerves coming out of there that function and for double vision, swallowing difficulties, facial numbness. The cerebrum's not too far away. There's a lot of things that work with thinking that are kind of close by. So some patients actually also have cognitive issues too that are pretty mild, but can still be distressing to them. With the cerebellum, you can get ataxia, incoordination, and also speech. We call it dysarthria, sort of not speaking very clearly. And then also the spinal cord, beginning of the spinal cord's right there as well. So you can actually have weakness in your arms and legs as well in some cases. So those are the neurologic impairments. And then I also categorize musculoskeletal impairments as well that can happen in different regions. So the skull base, you can have muscular neck pain. In particular, if they have to go through the back of your neck, they go through your nose, you probably have less sort of collateral damage that way. So if radiation, where did the radiation go? That can also affect the musculoskeletal symptoms you experience. In the mobile spine, that's similar to what traditional spinal cord injury patients usually have. Often have their injuries, but you can have paraplegia, quadriplegia. Usually it's an incomplete, so you still have some strength. You're not completely weak in most of the patients. Numbness, muscle spasms, bowel and bladder problems, so incontinence. We call it a spastic bowel and bladder, which is very different from the sacral tumors. And then you can also have back pain. Sacral patients also have weakness and numbness in their legs. They have a flaccid bowel and bladder, so it's a little bit of a different animal. Basically, the bowel and bladder, the muscle doesn't really push things out that much. So, and also the sphincter, the door to the bladder is usually wide open. So you'll have patients who kind of drip throughout the day. It can be very frustrating, and it's actually, for most physiatrists who are used to dealing with traumatic spinal cord injuries, this is actually a bit unusual, and they probably won't have a lot of experience with that. And then these patients also can have back and hip pain because of changes to anatomy and also changes to nerves. And also they also have muscle flap, frequently post-operatively have plastic surgery restrictions, which can affect their rehab course and their ability to be discharged home. So, Dr. Roldan also talked a little bit about this, but it brings up the concept of the kinetic chain. And basically, pain or a problem in one part of your body can cause pain and problems in other parts of your body. So think of it like when you have, let's say you're a really neglectful car owner and your alignment goes off. So your alignment goes off, what's the next thing that happens? Well, then my tires, they start to wear down. And then my tires, they probably will explode on the highway or something. And then I'm really neglectful, so I just don't have a clue. So I'm driving on the rim of the wheel, and then the axle breaks, and eventually the engine breaks, and you can see this sort of chain. And we're not cars, but it's sort of the same kind of concept happens with people. One problem, maybe they did a sacrectomy on my bottom, and then now I have weakness in my leg, and now I'm starting to have actually pain in my upper back now, in my ankle now too. It's like in a different place. But it kind of is all interconnected. We're not moving the way God designed us, and that causes inefficiencies. So what rehab can do is to try to bring us as close to normal as possible. We may not be able to we may not be able to bring the steering alignment exactly normal again, but we're going to try to do things to try to get it as close as we can. And your body's gonna work better if we can get you closer to normal as possible. So there's different types of rehab settings. Again, this is a very broad talk here, but in the inpatient setting, usually after your surgery, you may, not everybody needs it, but may need acute inpatient rehab, which is 3 hours a day of therapy. Skilled nursing facility, which is a little slower, 1 to 2 hours a day, and then long-term acute care, which is also 1 to 2 hours a day. So these are places where you would stay after your neurosurgical stay. And the goal for these types of rehabs are getting you home safely. So it's not to make you perfect, it's to just get you home safely. For outside the hospital, you can do it where you go to a rehab facility, that's called outpatient, or we can have the therapist go to your house, that's called home health. And in that setting is where we work on fine-tuning you better and trying to work towards, higher level goals that you may have. And in that setting, the patient actually has a lot of say in those goals. So, tell your therapist things that you want to do, things that you enjoy, your hobbies, because, and of course, myself and the therapist will tell you whether those goals are realistic, but that's good information and good things for us to strive for. There's a limited amount of chordoma rehab research out there. Actually, it's not very much. And I think a lot of that research that probably happens in the rehab world for this is probably lumped in with other tumors in that anatomical area. But there's been 2 recently published. Actually, it was this year, just so you know, about inpatient rehab for chordoma patients. And basically, they showed functional improvement. So chordoma patients improve on inpatient rehab, and so they should be brought to rehab if they have functional issues. One study did note that quite a few of them had to be transferred to the neurosurgery service or the oncology service for various reasons. And going back to this also issue of muscle imbalance in one part of the body causing more pain is that we have sometimes patients have, due to neurologic injury, have weakness in their back, or due to the anatomic changes that happen after surgery, have weakness in their back. And so sometimes we tell them to work on core strengthening, working on which is in the front of we work on your abs, which are actually in the front of your body here. And basically, just so you know, it's like, it's kind of like this person who's trying to fix his porch. This column here is broken, kind of like these muscles here, this vertebral column might be broken. So what does he do? He puts up some other columns here to kind of keep the roof from falling down. And that's kind of what we do in many of our rehab patients, is we work on trying to strengthen these muscles around the spinal column, as also the muscles in the front. And that's like putting more posts in there to keep that porch roof up there and keep it and that reduces the load on the vertebral column. So that hopefully that translates into reduced pain. This is something that comes up sometimes. We have patients who've had neck surgeries and they have sort of this forward flexed neck pattern, and sometimes I'll be asked to do Botox on them, botulinum toxin on them, which is basically a medicine to weaken some muscles. But a lot of times it's not due to spastic muscles making your head go like this. It's due to weakness, that your extensors are weak. And so it can sometimes be controversial because we could be making muscles weak to fight weakness. And so but this is something that you might run into, especially if you have a mobile spine or skull-based tumor. For the future of rehab, we've seen a lot of things come up that I think are exciting, and I just wanted to touch on this for you all. Prehabilitation is something that's kind of a really hot word now, a really hot thing in our world right now. And basically, it's rehab before your surgery or radiation. So like a boot camp for soldiers tries to prepare soldiers for the challenges of combat. Why don't we rehab you to prepare you for the challenges after your surgery? Why do we have to wait to strengthen your abdominal muscles or strengthen your paraspinal muscles until after the surgery? Why don't we do it beforehand? If you can tolerate it, let's do it. Let's get you prepared for it. And maybe that afterwards you'll have a smoother course. That's the idea. It's starting to gain steam, and so this is something you may hear more about. Technology is also a really exciting area for our field. when I started in rehab, when I'd go to the big rehab conferences in the exhibit halls, it would be mostly pharmaceuticals out there. Take this pill, take that pill. Now you go there and you still see the pharmaceutical guys, but now you're seeing all these gadgets there, these robots and really cool technology sort of coming into our field. So I think this is in the near term. It's already happened. Part of it's already happened. I think it's just going to continue to grow. This is something you might see. It's called a locomat. It has a treadmill. The idea is to try to get you to walk, or to get your gait pattern as close to normal as possible. That will hopefully stimulate your brain and spine to rewire to try to regain that normal gait pattern. This is called exoskeleton. Kind of does the same thing without the treadmill. These are really I see a lot of manufacturers making these. There's probably about 2 or 3 models out there. This is called an electrical stimulation bike, but basically this gentleman here has patches on the muscles here, and these patches are stimulating the muscles in his legs to go around, to push this bicycle pedal around. And this is an EEG cap, and this patient's actually controlling this robot arm with his head, with his mind, without because it's able to read the EEG signals. So these are areas that some of this stuff is available. These 3 over here. This of course is not there yet, but I don't think it's too far off into the future. With stem cells, we're not there yet. You may see places, especially in foreign countries, charging thousands and tens and thousands of dollars to treat you for that, but the evidence is still not there. So it's very hard to talk about so many different stages of rehab for so many different stages of cancer patients. But one thing I think I could talk to you all about is about exercise for cancer patients. It's been reported that only 21.5% of cancer survivors can recall a discussion regarding exercise with their healthcare professional. So how many of the patients in here can remember talking to their oncologist or primary care doctor or somebody about exercise? Yeah, so okay, so maybe we're better in 21, or maybe we're around 21.5%. I know there's some family members in here too, but that's pretty low. And this is a good conversation to have. So I'm going to have this conversation with you guys today, and the other 4 or 5 of you who've already had this, this will hopefully be a refresher for you. But there's been some research that has shown that patients who exercise survive longer. And this is a study of lymphoma patients who self-reported that they participated in exercise, and also some of them who went into a supervised exercise and control group. And basically, this is called a Kaplan-Meier curve. Basically, the patients who participated in this exercise program at time 0, way back here, so it was like, for some patients, it was years ago, showed that they were able to live longer than the patients who did not participate in that. And one of the things that might be going on here is inflammation. So inflammation has been associated with lots of different chronic diseases, including cancer. And this is Time magazine many years ago. But basically, exercise reduces inflammation by secreting things called cytokines. And in this graph, we see IL-6 and exercise duration. You can see the more you exercise, the more IL-6 is secreted. Basically, they come from muscles. So muscles do more than just move your bones across a joint. They also secrete things called myokines, which are proteins that are anti-inflammatory. And fat, those secrete cytokines that are pro-inflammatory. So it brings up the question, is exercise a cancer medicine? And I think the research is starting to show more and more that it is. It's been shown in multiple studies to reduce symptoms that patients may experience, including fatigue, pain, depression, insomnia, but it also may prevent cancer recurrence and progression, and inflammation, could make it come back. So that's why, I think you guys should all exercise. This is a study, there's not a whole lot of study on chordoma patients, like I said, but this is one study with chordoma and inflammation. Only 24 patients, but basically in this Kaplan-Meier curve, they were able to show that patients who had higher levels of inflammation back here at time 0, or near the beginning here, these folks here had greater than 1 milligram of this C-reactive protein, which is a pro-inflammatory cytokine, did not live as long as those who had lower levels of this inflammatory cytokine. So, that's great, Jack, you told me I need to exercise, but what does that mean? And we often use, as my job as a physiatrist is often to educate our patients on what types of exercise to do. The guidelines right now in 2010 are to do 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise. That's from an aerobic perspective. Of course, you have to do strengthening exercises and flexibility exercises as well. And what does that mean? Moderate and high, and that means my 15 minutes is up. But the things I like to use are the talking test and the heart rate. So for the talking test, you can talk but not sing. So you can, whatever activity it is, you can talk, but it's hard to sing. So that's 50. Or you could look at it as your heart rate is 50 to 70% of your maximum heart rate. I'm going to go through the math here in a second. The high intensity exercises, it's hard to say more than a few words during it. And that's about 71 to 85% of your max heart rate. Now, the reason this is important is because I understand that many chordoma patients have had surgeries, their anatomy has changed. These examples here of brisk walking, it might be a lot more work for you to briskly walk 2 blocks down the street than it is for someone who has a normal hip or a normal sacrum and normal nerve. So you can't go by these examples for many patients. This is a way to help you dose what you're actually doing. The talk test as well as the maximum heart rate. So the maximum heart rate, 220 minus your age. So in this example, we have a 60-year-old male. That's 160. So take 220 and subtract your age, and then use the percentages of that max heart rate. So 50 to 70% of 160. That's the range for your moderate exercise. This is the range for your high intensity exercise. Now, this used to be kind of a pain in the butt in the past because you'd have to stop what you're doing. You had to put your fingers on your wrist and figure out how fast you're going. But now with Apple Watches and Fitbits, it's actually pretty easy to figure out what your heart rate is. And some of them are able to even tell you how many minutes of moderate and high intensity exercise you did. So I hope that, in this short time I was able to kind of give you a crash course on exercise and rehab. Thank you very much for your time.